is our first live telecast to Russia. We've done other countries in the past, and I'd like to say hello to all my friends in the audience and all those in the audience who will become friends in the future, which hopefully will be everybody. I was going to do this live, but because of the scheduling of the program, I'm doing this on tape, and then I will be on live later when we have our transmission. I want to talk today about exfoliation syndrome, which is a whole different disease from what people thought it was 20 years ago. These are my financial disclosures. Now, Carlton Gajdusek, who got the Nobel Prize for his work on Kuru, said once, "It is important to explore, to do things others ignore, but it will become important in 10 to 20 years." I've been working now for about 35 years, even more, because I started when I was a fellow on exfoliation syndrome. It's a fascinating disease, and it is a distinct disease from others that cause glaucoma or other types or forms of glaucoma, whatever you want to call them. It was discovered 100 years ago in 1917 by Lindbergh in Finland, who wrote it for his medical thesis, but didn't get credit for it for many years because he showed his work to others and they published it without mentioning his name. Something for everybody to be careful about. And if we look for 100 years, basically, this top portion was glaucoma. Then in the 1980s or so, people started looking at ischemia and blood flow to the optic nerve. This was prompted by the introduction of metaxolol, beta-1 blocker, and it was shown that metaxolol improved blood flow to the optic nerve. Calcium channel blockers were described as improving optic nerve head blood flow also. But there are a lot of different disorders down here which cause ischemia of the optic nerve. And these have been called risk factors, but they are actual diseases in and of themselves, like atrial fibrillation, sleep apnea, nocturnal hypotension, peripheral vascular dysregulation, which is now called Flammer syndrome. All of these can lead to ischemia of the optic nerve. Then there's another vague category which has not been explored well yet that might be primary diseases or disorders or risk factors primarily centered on the extracellular matrix of the lamina cribrosa. Then I will mention over here low spinal fluid pressure, which Joost Jonas has been the most active proponent in this area. But we can't measure this. We can't test for this. We can't measure this non-invasively. And even if we measure it invasively, we can't tell, or we don't know, if the spinal fluid pressure at the base of the lumbar spine is the same as that in the brain. So we will leave that alone for now. Now I want to mention one disorder or combination of disorders which reflects on what I'm going to say along the way. We described combined pigment dispersion and exfoliation a number of years ago, maybe 15 years ago. And it occurred in people who had pigment dispersion in the past, which was now either burned out or well controlled, and suddenly went out of control in one eye. And we pinned it down to the development of exfoliation syndrome, which is another pigment-related disease in one eye, and called it overlap syndrome. Overlap in the sense that first they start out with pigment dispersion, it's under control, it's gone away, and now another disease starts up. Pigment dispersion, as you know, is a disease of younger people, and exfoliation of older people. And in any of these disorders, a number of different risk factors can come into play. It's not necessarily that you have one entity. You can have one specific entity and a number of different risk factors, and the more risk factors you have for glaucomatous progression, then the faster it progresses and the more severe it can become. So let's look at exfoliation and compare it to pigmentary. Exfoliation classically gives you a three-ring sign. You see the central disc, clear intermediate zone, and peripheral granular zone. Whereas in pigment dispersion, you have this mid-peripheral iris transillumination defects in a radial pattern. In exfoliation, you get transillumination, but it is at the pupillary border. This slide, it doesn't show in this slide, and it's not meant to. This is not a whole rundown of all the findings in exfoliation syndrome. Here is the typical angle in exfoliation syndrome. We see kind of smudgy pigment on Schwabe's line, on the trabecular. We kind of see smudgy pigment on the trabecular meshwork. It's not even, and it may correspond in some fashion to the outflow channels. There's pigment on Schwabe's line, and then on the peripheral corneal shelf, this wavy Sampolizi line, which is pretty much characteristic of exfoliation syndrome. So coming back to here, I'm just going to mention on this slide, once again, to keep in mind that normal tension glaucoma, what we've called normal tension glaucoma all along, falls into this area. But you can have exfoliation syndrome, which is typically a high-pressure glaucoma, a very high-pressure glaucoma. But if you have exfoliation syndrome and also have sleep apnea or nocturnal hypotension or atrial fibrillation, then you can get more rapid progression of the glaucoma. What we could not find right after we described the overlap syndrome was the next thing we thought we'd look for would be exfoliation syndrome with normal tension glaucoma, which should progress rapidly. We had a great deal of difficulty finding these patients, and we still have. We do not see many patients with what we would call normal tension glaucoma and also exfoliation syndrome. And I will defer the discussion of why, because that takes a while. Now, overall, exfoliation syndrome is the most common identifiable cause of open-angle glaucoma in the world. It accounts for the majority of cases in some countries, like Norway, Iceland. It's extremely common in Russia. When I was in Kazakhstan, 7 out of 10 patients they showed me had exfoliation. It's rare in other countries like southern China. Okay, but it is not a form of glaucoma. It's not a type of glaucoma. It's an ocular manifestation of a systemic disease, and we will come to that. But the main thing, it has specific mechanisms of causation, development, and distinct biochemical and cellular abnormalities. And this was overlooked for 90 years. Okay, I came out of the Harvard biology department in the early days of cell biology when everything was being discovered on an electron microscopy, ribosomes, synapses, mitochondrial cristae, and everything we thought of was in terms of mechanisms, and that's what carried me through basically my entire career. And I said, this is a disease with specific mechanisms, and if we can interfere at any step through the mechanism before the elevated intraocular pressure occurs and before they get glaucomatous damage, then we can stop a significant proportion of glaucoma. And it is very significant because the Lindbergh Society, which we started about 20 years ago to study this, which only had 30 members then, we estimated there were 60 to 80 million people in the world with exfoliation syndrome, but it was largely ignored and underdiagnosed until recent years. And hardly anybody was doing any research on this. Methods. Here is the classic pattern with the central disc, the intermediate zone, and the peripheral granular zone. The intermediate zone is created by the iris rubbing over the lens when the exfoliation becomes thick enough to rub off. And during its normal excursions, and remember this mechanism, it's basically during the normal excursion of the iris across the lens during constriction and dilation that allows the iris, when it lands at the peripheral edge of where it's going to touch the lens, starts scraping off exfoliation material, and it stops when the iris doesn't go any further in normal pupillary. Now, what about directed therapy? Okay, this is a very simple term. All it means is specific treatments for specific diseases. It hasn't been applied in glaucoma. In glaucoma, you just knock down you wait till the pressure's up, don't do anything about preventing the pressure from going up, and then try to hammer it down. Whether it's medicine, laser, surgery. The ideal treatment is to prevent its formation, or remove the material before the glaucoma develops. If a pressure is 40, the way what's been applied until now, if the pressure is 40, you make it 20. If it's 30, you make it 15. If it's 20, you make it 10. If you're a Neanderthal and the only tool you have is a hammer, then everything looks like a nail. And so we need to find discover the mechanisms leading to glaucoma and treat the risk factors leading to the disease. In the past 5 years, exfoliation has hit worldwide prominence, partially because we devoted all of our Glaucoma Foundation think tanks to exfoliation. We decided to put all our efforts into exfoliation. We've given $1 million in pilot grants, and I got $1 million from a patient to work on the cell biology, which we'll come to. The only specific therapy we have at the present time, though, that's practical is mydriatics. Now, nobody uses pilocarpine anymore. People think of 4% pilocarpine 4 times a day, and it causes meiosis and decreased vision and posterior synechia. That is not necessarily true. Mydriatics are the one drug that we have that increase aqueous outflow, and nobody uses it. We have drugs that increase uveoscleral outflow and decrease episcleral pressure and decrease inflow. We have no good drug except pilocarpine for outflow. And what we found was that 2% pilocarpine at bedtime limits pupillary movement. It gives you a 3 millimeter non-reactive pupil for 24 hours. And that stops the iris from rubbing against the exfoliation. That stops the iris from rubbing against the lens, and it decreases or eliminates the scraping away of the exfoliation material from the lens. It decreases the pigment release from the iris, and it slows down the disease markedly. And we combine that with prostaglandin analogs. Those are my first choice is a prostaglandin analog, and then add a mydriatic if the pressure is still it's either fluctuating or is still too high. And Bernie Becker in 1985 in the Journal of Glaucoma wrote a great editorial, which all the residents ought to look at, suggesting that aqueous suppressants like beta blockers may worsen the disease by slowing aqueous flow through the trabecular meshwork. Okay, so what else can we do? Okay, the one thing we have is pilocarpine, and it really works well. 2% at bedtime, not QID. Maybe we can depolymerize. The next step is, how can we get rid of this material? Can we depolymerize it? Well, Carlo Montemagno, who's a leading nanotechnologist in Canada, came up with the idea of using engineered nanoparticles which get through the cornea with a engineered shell that can penetrate the cornea, break up inside the anterior chamber and attach to the exfoliation material, and then use magnetic energy to break up the aggregate either physically or thermally. And that's just one nanotech idea as a whole nother future nanotechnology is being used in medicine, and it's beginning right now. So now we said, well, maybe there's other LOXL1 disorders that have not been associated with exfoliation syndrome, but that are abnormal, that they're abnormally present, or that there's an increased prevalence of these diseases in patients either with exfoliation, LOXL1 abnormalities. And Barbara Warosco suggested this to Barbara Warosco a few years ago, and she's in Salt Lake City, where they have a Utah database for the Mormons. And Mormons are meticulous about their databases for medical histories, and it goes back about 8 generations. And in 2008, Alperin et al. Had reported that LOXL1 knockout mice had pelvic organ prolapse. They said, you know, maybe there's an increase in LOXL1 abnormalities, LOXL1 mutations in patients with pelvic organ prolapse. And Zhou et al. Had described the decreased expression of LOXL1 and fibrillin 5 and suggested a defect in elastic fiber remodeling. Well, that set us off on looking at elastic fiber diseases. And last year in JAM Ophthalmology, we found that the risk for exfoliation syndrome in women with pelvic organ prolapse was 3 times as high, and that exfoliation may be associated with pelvic organ prolapse through damage and impaired LOXL1 repair to elastin containing connective tissues. We couldn't work the other direction because exfoliation was not diagnosed. And so it was really way, way underdiagnosed in the Utah database. So we worked with the patients with POP and found the increased incidence of exfoliation syndrome. There are other LOXL1 associated disorders, and I'm not even getting into non-LOX, to other LOXLs. Remember, there are 5 LOX. There are 5 LOX genes. Well, inguinal hernia was one, varicose veins, endometriosis, subacute cervical artery deficiency, I think, is the most common stroke, is the most common cause of stroke in people under the age of 55. And for years I've been saying, we don't have a neurology ward here. We don't have neurology patients. But those who are in hospitals with neurology wards, to look at patients with cervical artery dissection to see if there's an increase in exfoliation syndrome. The reason being that one of the LOXL1 is a major candidate gene for SCAD, and one of the SNPs associated with exfoliation syndrome showed a marginal association with SCAD. So this is a place to look, but nobody's looked at it yet. And there may be other disorders also. Well, this year at ARVO, we took, again from the Utah database, we looked at inguinal hernia, found out there was a significant increase in inguinal hernias associated with exfoliation in men. And what's really interesting is COPD, chronic obstructive pulmonary disease. Well, if you have exfoliation syndrome, you have 25% greater chance of developing COPD. If you have exfoliation syndrome and COPD, you live longer than people without exfoliation who have COPD. And so there's something about exfoliation, even though you have all these disorders associated with mortality, that allows you to live longer. And we don't know what it is looking for that. There's a gene-environment interaction, apparently. Lou Pasquale at Harvard has been concentrating on this, and he has described increased exfoliation associated with the amount of caffeine intake. Caffeine intake is very high in Scandinavia, so is exfoliation. Solar exposure. People in the desert. There have been several growth factor abnormalities. I'm going to skip those. The main thing to remember is that there's elevated TGF beta 1 in exfoliation, which is normal in POAG. And there's elevated TGF beta 2 in POAG, whereas TGF beta 1 is normal. Beta 1 induces the synthesis of extracellular matrix, and we hypothesize a strong role in the pathogen. Now, lysosomes are intracellular vesicles that degrade waste. Okay, they're garbage pails. And the accumulation of undegraded protein aggregates underlies all the neurodegenerative diseases. It's found in Parkinson's, Alzheimer's, ALS. And the lysosomal abnormalities could cause accumulation of abnormal exfoliation material. And the drugs, I'm jumping ahead now here, if that's all true, then drugs that improve lysosomal function may help to reverse exfoliation syndrome line. We looked at one drug, Davunetide, which is a peptide in trials now for Alzheimer's and other neurodegenerative diseases, which stabilize microtubules and improve lysosomal function. Here's exfoliation cells without Davunetide, and when you give them the Davunetide, look, they bind to the microtubules and migrate to the perinuclear center. So what's going on? Is this a treatment for exfoliation? So far, nobody has put in for a clinical trial, but that's something that ought to be done. Mitochondria are also depolarized. And remember, mitochondria die before nerve cells. Mitochondria, the axons, the dendrites are packed with mitochondria. The mitochondria go, then the axons go, then the neuronal cells die. And that happens in Alzheimer's, Huntington's, Parkinson's, ALS. And the same thing appears to happen in exfoliation syndrome. So we want to improve autophagy. We want to stabilize the microtubules, and we want to activate the autophagic signaling pathways to get them to work to get rid of all the junk. We want to increase chaperones, which I really haven't mentioned, and I'm not going to say a lot about. We want to improve mitochondrial function with mitochondrial stabilizers, targeted antioxidants, and perhaps rapamycin, which I'll mention briefly. Now, if we want to stimulate autophagy, there's a lot of things to do it, okay? They're all over the place, including simple things like aspirin, melatonin, many natural products. And I'm not going to mention most of these. What I'm going to mention is possible treatments for mitochondrial preservation. Autophagy continuously removes aging mitochondria, okay? We've kind of gone through that. Stimulators of autophagy include a number of different compounds, including resveratrol, which I didn't mention, melatonin, and nicotinamide. References in here, but the paper by Lin et al. Showed that it's essential for vision in mice and prolongs lifespan. It's kind of like resveratrol or caloric restriction, but they showed that it is essential for vision and prolongs lifespan. And I started taking NAD the day after I read the paper, because more has come out, another paper out of Simon John's group with nicotinamide, also known as vitamin B3. It also was reported to prevent glaucoma in mice, but the amount given to the mice would mean you have to take about a pound a day. So that's up in the air, but it is, again, a very strong mitochondrial inhibitor. And goji berry or wolfberry, which has been worked on for many years by Sokwak Fai in Hong Kong, is also neuroprotective. Just to mention this, rapamycin is an antibiotic and may improve mitochondrial remodeling and reprogram energy metabolism. And another drug like that is simvastatin. These are antibiotics. Can they help in exfoliation? I don't know. But rapamycin enhances autophagy and decreases the number of degenerating neurons in axotomy. I'm going to skip here. The systemic associations and their importance need further study. Non-pressure lowering treatment modalities are potentially applicable to exfoliation syndrome, and I think that the more we look at these and the more we find and the more possible modalities that are piling up, I think that the lowering of intraocular pressure is going to become less important because we will be able to find ways to stop exfoliation syndrome before it gets to the level or gets to the stage of elevated intraocular pressure. Thank you.
Глубоко уважаемые коллеги, мы
Distinguished colleagues, we are a little bit behind the schedule. Professor Ritch's version is very long. It is provided in full translation on our website, so you can refer to that originally. But now we would like to appreciate the clinical case from the clinic. I think it's very interesting, and then we'll start with videocast. So please introduce the video case.
Cannot improve is a defeat that must encourage us finding additional ways to preserve vision. Good morning, Moscow. I am Luis Silva, and I work at the New York Pioneer with Bob Ritch, and we want to share this clinical case with you. We want to present a 74-year-old architect woman with exfoliation glaucoma in the left eye. Actually, she is from Russia, and she came years ago to the U.S. to follow her dreams of designing bridges in New York City. She had high intraocular pressures in the left eye that were controlled with a trabeculectomy with mitomycin C, and she eventually had a cataract extraction with PCIOL in the left eye. She has hyperlipidemia, for which she uses atorvastatin, and she also uses aspirin 81 milligrams daily. She went for her regular follow-up with her ophthalmologist. At that time, intraocular pressure was found in 24 millimeters of mercury in the right eye and 12 in the left. And cataract extraction in the right eye was recommended. She wanted to request a second opinion. In that second opinion, intraocular pressure was 36 millimeters of mercury in the right eye and 14 in the left. There was exfoliation material on the lens in the right eye, open angles. The patient says that during the evaluation, she received several drops to dilate the eyes. And additionally, she received a drop of dorzolamide timolol in the right eye to decrease the intraocular pressure in the right eye. What happened next is that during the day, she complained of the sudden appearance of a central scotoma in the right eye. She called the office and she was asked to return to the office the following day. The following day, she was re-examined and they didn't find anything, and she was told to wait a few days for recovery after the pupillary dilation. 4 days later, she went back. A retina specialist looked at her and found a basic normal eye exam regarding the retina, and except for a posterior vitreous detachment in the right eye, and she and the retina specialist ordered a macular OCT and 10-2 visual fields. The patient decided to come to us for an additional opinion. When we saw her, vision was 20/25 in the right eye, 20/30 in the left, +1 nuclear sclerosis and exfoliation material in the right eye, and the left eye had her vascular bleb with iridodonesis and the PCIOL, well-centered and mild posterior capsular opacity. Pressure was 21 in the right eye, using dorzolamide timolol only once daily, and 40 millimeters of mercury in the left eye. And this is the image of her retina and the aspect of her optic nerve. So as you can see, in the right eye, we have a basic normal appearance of the retina, and the left eye has the pallor of the optic disc. This is where she had very high intraocular pressures that were finally controlled with surgery. So our focus here is going to be the right eye. And here's the 24-2 visual fields that she brought, that were made initially by her regular ophthalmologist. And you can see the central scotoma in the right eye and the inferior arcuate scotoma in the left. I'm going to focus on the right eye because this is the reason why we want to share this clinical case with you. This is the 10-2 visual field of the right eye. As you can see, there was a previous one obtained in 2011, which was basically normal, and the left eye revealed this scotoma, paracentral scotoma in the right eye. This is the RNFL OCT and retinal ganglion cell layer OCT, which was basically within normal limits. So our question is, what happened here? We saw retina, which is basically normal, but we had a patient with a sudden visual loss, or I correct, with the sudden appearance of a central scotoma. She was in panic because her life is the whole day in an office designing bridges. Imagine her in front of her computer with a central scotoma that doesn't allow her to work in the computer. So she was really in panic. And what should we do? So we need to think about acute causes of visual loss. So we're thinking about basically ischemic causes. So I'm going to put you some examples here of what could other causes be, to cause this sudden scotoma, central scotoma. We thought about the possibility of a ciliary retinal artery occlusion. However, in ciliary retinal artery occlusions, as I'm showing you here in the photo inferiorly, we would see a blanching of the retina because the edema and infarction that occurs there. So obviously that wasn't the case in our patient. Could have been an anterior ischemic optic neuropathy. In AION, usually you don't have paracentral scotomas. Usually you have more altitudinal defects, and we usually see small discs with look edematous. We can see engorgement of the vessels. That wasn't the case in our patient either. Could it have been glaucoma progression? Well, glaucoma progression doesn't present like that acutely. I mean, the patient mentioned that the central scotoma appeared suddenly after several drops were applied during a regular ocular exam. And as we can see, there are RNFL OCT and the RDC plus OCT, layer OCT doesn't show any signs of areas that could explain paracentral scotoma. So this is the answer here for this case, the macular OCT. And as you can see here, there is an hyperreflectivity band at the inner nuclear layer of the retina, at the paracentral area of the macula, in the nasal area. And This is compatible with what we call the paracentral acute middle maculopathy, which is called basically by ischemia of the middle area of the retina, the middle layers, and basically caused by ischemia of the intermediate and deep retinal capillary plexus. When OCT didn't assist, we could not see at which level ischemia occurred in the retina. We only had fluorescein angiographies, and we could see areas of ischemia, obviously, in the retina, but we couldn't see at which level it was. Now, with with the new technology, and we have now very good resolution of the devices with OCT, we can see the layers and we can detect at which ischemia happened. So paracentral acute middle maculopathy has been described recently, from 2013, and it was differentiated from what is called the acute macular neuroretinopathies. And we don't see anything usually in the retina on the fundoscopy because ischemia occurs in the middle layers of the retina. So, and the risk factors for paracentral acute middle maculopathy, among those are the use of agents, pressor agents or vasoconstrictors, such as sympathomimetics or epinephrine, norepinephrine, or high doses of caffeine. So you can search in the literature and you will see that there are reports related of these cases related to the use of oral medications as vasoconstrictors. So we had to, rule out other causes and try to find out why this patient developed these paracentral acute middle maculopathy. So we had to rule out other causes as if the presence of migraines, which she denied, the use of other medications, which she denied, including amphetamines or vasopressors, and she denied using caffeine that day, and there was no previous respiratory infections or any flu-like symptoms before. We sent her to her cardiologist who did an evaluation and obtained a carotid and vertebral duplex Doppler study, and he only found less than 40% stenosis of both internal and carotid artery, trying to find areas of boluses that could have caused a embolism. We didn't obtain a transesophageal ultrasound, which would be more precise, but the Doppler study made by her cardiologist did not find, clinically significant stenosis of the internal carotid and arteries. ESR, CRP, and the basic metabolic panel and the lipid panel was within a normal range. 2 months later, so because this is important to know what happened after this. So what is the prognosis? So 2 months later, intraocular pressure was 30 millimeters of mercury in the right eye, pretty high, with dorzolamide, timolol, BID, and 15 in the left, which was decreased by adding latanoprost and pilocarpine 2% at night. So 6 months later, visual acuity was 20/25 in both eyes. She had a yak capsulotomy in the left eye. And the pressure was 19 millimeters of mercury in the right and 14 in the left. And you can see here the visual fields, one obtained after the episode of paracentral acute middle maculopathy in 2015, and 5 to 6 months later, the scotoma, which was still there. We obtained 18 months later this macular OCT, and we can see how now we can see an atrophy of layers, and middle layers of the retina, and which is the sequelae here after this ischemic insult. We didn't have the OCT angiography when she first came. Now we could obtain it now because we have it, and we can see this is an OCTA showing a decreased vascular density nasal to the fovea. But definitely OCT angiography now is an important additional evaluation when in sudden visual loss in the central vision. To sum up, we wanted to share with you this case as the first to our knowledge of paracentral acute middle maculopathy after pupillary dilation in a patient with exfoliation syndrome and exfoliation glaucoma. This was the only risk factor that we could find associated with her condition, and she developed a sudden visual loss with central scotoma after receiving several drops from a regular eye examination, and we think that speculate that she or suspect that she should have received several of phenylephrine topically that could have increased the risk to have an ischemic episode such as the one that she had. We wonder if there is a higher risk in exfoliation patients because, as we know, exfoliation is strongly related to systemic vascular disturbances. This is interesting to take into account if we're having patients with exfoliation, just to take precautions when we are dilating. We know that these patients do not dilate very well, but please keep in mind, trying to avoid phenylephrine in excessive doses to dilate the patient until further studies may confirm this association. Thank you very much for your attention, and thank you for the invitation. До свидания.